Is junctional rhythm a dependable rhythm?
No.
Okay. Is it on your test? No. Okay. Now I feel better about I have a clear conscience. Now SVT is not going to be on this test, but you're going to see a lot of patients in it, even you may be in it. And so where is this coming from?
Atrium.
Above the ventricles. Does it come on sudden?
Yes.
Okay. So is it fast up here?
Yes.
Yes. So here's the treatment for this. You say, oh my. What does that mean? Oxygen. Monitor. IV. You with me? And then you say to yourself, how can I stimulate my nervous system to slow this down? Remember the brakes? Remember your parasympathetic nervous system or your brakes? So what can I ask them to do if they can follow directions?
Bear down.
Bear down like they're having a bowel movement. That's called the Valsalva, right? And so you're going to have them bear down. And what should that do? Should help to slow down their heart rate. It doesn't always work. If you can't communicate with them, you can put a straw in their mouth, like with a child or a demented adult, and say, blow, 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 and you occlude the other end of the straw. Okay? And you're helping them do it. Does that make sense? All right. So, again, we talked about oh my, and then we had a vagal, didn't we? Okay. Tried to have them bear down like they're having a bowel movement in an attempt to release acetylcholine, and that's your brakes. Do y'all remember that? Okay. So if that does not work and your patient is symptomatic, hopefully you have contacted your supervisor on your unit rapid response team, because unless someone is ACLS certified, they can't give this medicine. And the medicine that we give for a fast SVT is called adenosine. And you don't have to know that this semester. We will cover that next semester. And adenosine is a medicine that works within seconds. The half-life is less than 10 seconds. And you got to get it in fast. And it's could possibly cause the patient to go into asystole, so they're going to have all kind of resuscitation equipment. So did y'all hear me?
Yes.
You can't push it if you're not ACLS certified. So even if a doctor's barreling down your back going, just go get it, it's in the crash cart, you can hand it to them to give, but you really need to go ahead and call rapid response or your supervisor, because you're going to need the crash cart and all that stuff at the bedside. And to do it safe, you need a lot of equipment, okay, and people who know how to give it. Make sense?
You're saying for SVT?
For SVT, okay? Adenosine. If it's not on your test, we will test on this next semester. Adenosine. But the reason I tell you is every day in med-surg, there typically is a turnover with physicians and nurses, as you know. And there will be newer nurses out on a med-surg floor, and there'll be a newer doctor, and they'll have a patient that goes into SVT, and they'll want to get it. And they'll say, just go get it and give it. And they'll almost be like, and you just say, one moment I've got to get someone who's ACLS and certified to push that. No problem, we'll get it done. And you just get someone from the unit, your supervisor, somebody. But we have nurses from time to time that will just literally do whatever a doctor tells them to do. And is that smart? So what is your role is to protect the patient? You wouldn't want your family to get it if the person giving it didn't understand about the drug. So you don't just say no to the doctor, you just say, we'll make that happen just one moment. You know what I'm saying? Yes, sir. Or yes, ma'am. And, you know, you don't tell them what you can't do, you tell them what you can do. We have them on the way. Okay? Otherwise, you're going to be in a fuss match. And you don't need that. So the one thing I want you to understand up here when you're looking at SVT is the complexes are extremely what? Narrow. So it's a narrow complex pack is what they're going to call it in your books, in your studies. And with the rate being this fast, what do you think their cardiac output is?
None.
They're going to be short of breath, and you're going to have those signs and symptoms that we talked about as far as decreased cardiac output. So that's why you want to make sure you're having them rest, get them into bed, have them bear down. So we're trying to do the non-invasive correction first, which would be easier if someone vagal down to literally sometimes having a bear down like they're having a bowel movement, they'll convert right back to sinus rhythm. And that's all you needed. Isn't that wonderful? No meds, no nothing. That would be a much better treatment than having to give a medication that has some pretty good side effects. Believe me. We'll talk about that next semester. I don't want to waste your time. Now these are practice strips. So the one on the top, I see P waves, QRSs, and Ts. It's just all pushed together, and they're married. And so that's coming from the sinus node. So is that too fast? So that sinus attack. Now the one in the middle is one that they start off in sinus rhythm. Do y'all see that? And then you're going to have something that jumps in early. Look at the third one from the right. Do y'all see that? And that is a PAC, the third one from the right. And you see where the sinus node kind of had a little bit of a pause and said, whoa, what was that? And then the sinus rhythm picked back up on the last two complexes on this strip. So the third one over, counting this direction, is your PAC. Y'all see it? Okay. The one on the bottom is too slow. Do you agree?
Yes.
There's a P for every QRS. So that's sinus rate. Okay. Now, here we're cooking. The one on the top is the most common one. Atrial fib. And how do you know it's atrial fib? Because it's irregular and the chaotic baseline. So now look at the one in the middle. You got P's married to every QRS, don't you?
Yeah.
So that's coming from what?
Sinus.
And so that's normal sinus rhythm. But look at the one on the bottom. All right, so it's regular, right? It's regular, but is there one P married to every QRS? No. No. Does it look like a noose saw in between there? And so that's atrial what?
Flutter.
Very good. So those are the one on the top, the one on the bottom. Those are our main things we're covering. And then that PAC one you saw. So when a patient's having a dysrhythmia, it could mean that the patient's asymptomatic, right?
Right.
Because patients are in sinus brady all the time, and they're asymptomatic. That doesn't mean they need treatment, but we would call that an arrhythmia or a dysrhythmia. But there are certain times when patients have dysrhythmias that their cardiac output is altered. And so in that case, then we need to, again, ask them about their history and find out, do you have a history of any heart problems, any rhythm disturbances, ever been told that your EKG was not normal? Those are some of the things we will ask them. But, just get a good history. It can tell you a lot. The thing we worry about, especially with atrial fib, is the rate. Y'all remember that? And so, because they'll have decreased cardiac output. And a lot of times they'll come in not knowing what's wrong with them, but they're complaining of shortness of breath, weakness, fatigue, and they know something's just not right with them. And sometimes they'll say, I'm having palpitations or something's not right with my heart. And so that's when they come in through the ER and we do an EKG and we find it. So I've already covered cardioversion, talking about the toilet, remember? And defibrillation. So here are some kind of definitions of that. And you'll look in blue. What does that say? Anytime electricity is involved, do we need to be safe about it? Yes. Do you remember the important points we talked about with cardioversion and defibrillation? Okay. So there's that. They have their own version of the pacemaker and all that. So you can look at this. The picture is showing you the pacemaker under the skin. Do y'all see that? Y'all seen that before? Yeah. Okay. Here is a paced rhythm. Do you see the spikes? Yep. Okay. And what if I lost a few of those QRSs and only had spikes? What is that called?
Loss of capture.
Loss of capture. And so when that occurs, the first thing that I would do, if Jack is my patient, the first thing I would do is check how Jack is responding to that loss of capture. Is he symptomatic? Does he feel any different from that? Does that make sense to you, that the patient is more important than the device? Okay? Then the next thing I'm going to do is I'm going to increase the, what's that called? The amount of energy.
Current,
The current, but what,
joules.
it's joules. But do you remember what the word, I used some weird word, it's a marriage word that you carry your little bride over the
Threshold.
Alright! Woo! Y'all won the game. Do you remember I was talking about before the energy that it takes in order for the heart to respond to the pacing stimulus or the pacemaker? And I called that amount of energy the threshold. And so the threshold is the amount of current or energy, electricity, or joules, those are all the same thing, that it took for the heart to respond. Well, if the heart has quit responding to that, does it make sense to you that I need to increase the threshold?
Yes.
Yes, and remember I told you we always dialed up 2 to grow on? Aren't we all? Okay, so what you're responsible for this semester with pacemakers is, of course, the teaching part, but also loss of capture. So I like to go back through loss of capture. With loss of capture, you're going to have a pacing spike. And what don't you have following a pacing spike? QRS. Okay, and if that occurs, after we assess our patient and see how they're doing, what are we going to do?
Increase the threshold.
Increase the threshold of the current. Yes, good question.
When you're saying increase, you just interrogate it and change the purpose?
No, I'm talking about that subcutaneous.
Oh, it's for subcutaneous,
Yeah.
okay.
I'm talking about the subcutaneous one that you would, as an entry-level nurse, really you should never be operating the pacemaker, but I have been on floors where I was the newest person there, and I was the only one that remembered anything about the defibrillator from the training we just went to. And it was me and the doctor, and he was like, you know how to operate this thing? I said, I've had one class on it. He goes, well, you've had one more than me, let's go. And so he goes, I can tell you what I want, you just make it happen. I said, yes, sir. And so, look, I'm thinking, I hope I remember this. And so, but the patient is dependent on who? Us. And so, I knew how to turn it up. You know what I mean? It was just that little button. Wasn't that hard. And so, anyway, these are the pacer spikes right here. It looks like a little ink mark. Y'all see that? Mm-hmm. So that is the pacer spike. And the QRS, do y'all see how wide that is?
Yeah.
So that's not traveling normal conduction, because if it did, if that was from that patient, it wouldn't be so wide and bizarre. Does that make sense?
Yeah.
Okay, so the heart is responding in its own way from what? The pacer spike, and we know that because we have a QRS. And the heart's not responding if you've got a pacer spike and nothing. You with me? And that is called a pacer spike, and no QRS is called loss of capture. And that's what you have to know.
So is there a certain reason why the QRS is going down and not up?
According to the lead you're looking at. According to each lead is different. Like you have lead 1, 2, 3, and we go on and on. According to your system, they're looking at different. They're looking at different views. Like you look at a car, and so the impulse travels different directions according to which view you're looking at. Okay. All right. Okay. All right. Keep going. So, when we have a pacemaker going on someone, how do we know that that patient is tolerating it and that the output, that the patient is doing what it's supposed to do? So remember I said I was going to look at Jack if I saw I had loss of capture, I was going to see how he was handling it. Mm-hmm. How would I know that a patient is handling that?
He's still
He's still there. That means that their LOC is not changed. They're able to respond to me. They're not complaining of shortness of breath, chest pain, dizziness. Are you with me? The same things about cardiac output, but I just need to make sure that you understand. And the other thing is, after a pacemaker is inserted, should the patient feel better? Yes. And the other thing I wanted to ask you is, do you remember how you would know if the pacemaker was not functioning correctly? Any pacemaker. They feel bad, they feel yucky, I like hearing that word. What might they complain of with pacemaker dysfunction or malfunction? Shortness of breath, show a little chest tightness, discomfort, weakness, what do you say? Dizziness is a big one. Why do you think they're dizzy?
They're not getting enough perfusion.
They're not getting perfused to the brain. There's not enough blood pumping because there's not enough, they're not getting stimulated. Their heart's not getting stimulated to contract. And if it's not contracting, is any blood coming out making it up to their brain? Okay. And remember all that teaching stuff I told you needed to study? What do you teach a patient who has a permanent pacemaker placed? Remember all that? Can they have an MRI?
No.
All right, so you remember all these things we talked about. Remember about abductions? Okay. And you remember about infection being a problem?
Yes.
All right, so let's go back through all of it, but remember the 3 codes?
Yes.
The first 3, you got to know what they mean, is all I'm saying. First one is chamber taste. Next one, chamber sense. And the next one is what it does in response to what it picks up. You with me? Okay, that's all you got to know. You don't have to know. Somebody had looked it up, and I applaud them because some of the codes are like D, D, D. Do you need to know what that means? No. No. All right. Answer this question for me.
G.
What's the most common? Everybody agree?
Yeah.
It's D as in David, dog, atrial fib is the most common chronic arrhythmia.
D.
D.
You're so
You were
smart.
so smart. All right. So I kind of did a review. And so now you know what you remembered about pacemakers and what you don't remember about pacemakers. So you better be looking at your pacemaker stuff, especially that teaching stuff, because I don't have time to keep going into that. We got to hit the news stuff. Ready for the news stuff? All right. So we're talking about infectious and inflammatory. All right. Doesn't necessarily mean that they're all infected. May just mean inflammation, but it could mean both. So let's look at these. So the ones we're going to cover are endocarditis, pericarditis, myocarditis, and septic shock. So the first one up here says endocarditis. Where's your endocardium? It's the inside lining of the heart. That's where your valves are located. So that's the inside. So the trouble that we're having, or the problem, lies on the inside of the heart where the valves are located. Are valves important?
Yes.
And remember what they do. What do? They close and open, keeping blood flowing forward and not backing up.
Right.
And the problem comes when, if you ever had a door that wouldn't shut right, oh, how aggravating that is. Or a drawer, same difference. And so that causes a lot of problems. Endocarditis can cause a lot of problems with our valves. Okay? All right, so now, the next one up there I see is pericarditis. So the problem is where?
The sac.
The sac. So you've got to keep this in your mind, because sometimes if you can have a question and if you can think about what it's affecting, you're like, wait a minute, let me think about this. And you might can answer it just based on knowing where the problem is. All right? So pericarditis, and I'm just going to throw this out there. If the outside lining of my heart is all inflamed and irritated, what do you think happens when I lay back? Your heart is going to touch things when you lay back supine. It's going to hurt worse because that lining, that outside lining, is going to, you're going to kind of displace your heart a little bit when you lay supine. Okay? So if you move it and it touches something, I want you to think about an open sore that you touch. Does it hurt?
Oh, yeah.
So I want you to think like that. So a pericarditis patient is going to tell you that it hurts worse when they lay supine, when they lay back. It hurts. Their chest discomfort that they're having will be worse. It's also worse, if you think about this, it makes sense. When they cough, it's worse. Okay? So when they do if they swallow sometimes, it's worse. Anything that can potentially move it or cause motion is going to make it worse. Now wait until I tell you this. The patient with pericarditis, one of the ways we can kind of tell if that's what's going on, ask them to lean forward like this in the tripod position. This is the tripod position. I don't know if y'all can see me. I'm not real tall. But like this. Y'all see my hands are on my knees and I'm kind of leaning forward. I got something to kind of brace. So I am displacing that heart from touching to as much stuff. And there's something about doing this, leaning them forward, it feels better. And so that's a way that we can kind of start determining what's going on. Because when somebody says chest pain, y'all all go, oh God, they're going to die of a heart attack. And it may not be that. You with me? Yeah. And so there's a clinical picture of this that the patient's going to start telling you, well, kind of my left shoulder hurts, and y'all be like, you're having a heart attack? No, not necessarily. Sometimes they'll say their left shoulder hurts. Sometimes they'll say they're kind of hurt in their back right there by their shoulder. And then sometimes they'll say up here hurts, and you're like, and then what's that question y'all like to ask? Does anything make it better? What makes it worse? If you're thinking by any chance that this is pericarditis, what can you ask them? Is it worse when you? Yeah. And hey, position yourself like this. Does it make it feel better? So you with me? Yeah. So that's one of those things, like just knowing where the location is, you can kind of figure it out. The other thing that bothers me about pericarditis, and it's going to bother you too, so don't hit me, is your pericarditis patient will have ST segment elevation in all leads. And you'll be like, but how do we know the difference? Well, the clinical presentation's different.
Their troponin won't be elevated.
If their troponin is elevated, it's not gonna spike up like it would if they're having an MI. Okay? Because if you're having an MI, remember those enzymes. If you're having an MI, especially a STEMI, that's a big one. If you're suspecting, what are the enzymes supposed to do? Elevate and then come down. With this patient, if they're elevated at all, they might be. They're just going to be just like this. They're going to stay the same across the board. Okay? Getting it?
Yeah.
All right, you say it to him.
All right. So we're going to look at each one of these, but I'm just trying to help you use your common sense and a little bit of knowledge to do better on your test. Okay? So now, what about, we talked about myocarditis, it's not even in your book. In here. But what part of the heart is that affecting? The muscle cells. So when someone has an acute episode, and we had a patient in clinical last time I went that had this, and they were glad they had looked it up and knew about it. If you have someone who has myocarditis and it is in the acute phase, we're going to put them on bed rest. Does that make sense? Yeah. And we're not going to push them. And so this can be to where it's not even detectable in some patients, or it's extremely bad in some patients. But I'm not going to focus real hard on this one because, hint, hint, it's not in your book. All right, so septic shock. What's the problem in sepsis? I want to give you a high five. Sissy is the most common sense kind of girl ever, and I just love it. I love to hear what comes out of her mouth because she don't hold no punches. She just sells it like it is. And that's what it's going to take for you to be a good nurse. So in sepsis, the issue is the infection is not just in a local area anymore. Where has it entered? The bloodstream. Where does your blood go?
Everywhere.
Everywhere. Is that a problem?
Yes.
So if it's in your bloodstream, would you have positive blood culture?
Yes.
Yeah. Does it take a while for those blood cultures to come back? Yeah. So they're going to start an antibiotic anyway, aren't they? A broad spectrum one. But we always have to make sure we get cultures before we start antibiotics. Y'all remember that, right? Okay, so what's the deal with sepsis? What's the problem with sepsis? Well, once the infection gets in the bloodstream and it's going everywhere, the body has a response, a systemic inflammatory response that occurs. And so, again, we need to recognize that quickly, because the quicker we recognize it, the better outcome of the patient. So I've written up here on the board on this side, sepsis equals infection plus Sears criteria. Do y'all see that? Y'all get that down later. I don't care when you get it down. I'm not going to erase it when I get out of here. But the point I'm trying to make is, for whatever reason, on NCLEX, on ATI, on my test, I'll say who's at risk? Or I might say who's most at risk?
Elderly.
Someone with accident.
Person who has an infection.
Like
Something already in the body.
Okay, I'm with you that there are certain populations who are more at risk for infection, right? Old, young, HIV, you with me? Connective tissue disordered patients. But really, who is most at risk? Who is most at risk for sepsis and septic shock? Someone who already has a what? Infection. Because if you have an infection, just because you have an infection, because I've had infections before on little wounds or things over the years, have you? But it's just a localized infection. It doesn't mean it's where? In your bloodstream. But in order for sepsis to occur, there was an infection somewhere localized in your body, and now where has it went? Traveled. Everywhere if it got into your bloodstream. Does that make sense? And so this semester, I thought I was going to write it on the board. Okay. Sepsis equals infection plus what? It has some Sears criteria. And what does Sears stand for? Systemic Inflammatory Response Syndrome. Okay? And so there is a table that you need to look at. Is on page, I got it right up there, table 37.3, and it has all the criteria of sepsis. So if you'll start at 762, I bet you'll see that table 37.3. And it says sepsis with Sears. And I even wrote some of the main ones that I've seen recently. So if they have a known infection, we're taking care of them. And they had a cellulitis. Let's just say a cellulitis. Y'all know what cellulitis is.
Yeah.
And then we're taking care of them. They're on antibiotics. They're in the hospital because it's bad. And we look up and I go, what did you say her heart rate was? And you said, it's 102, Miss Cooper. Is that above 90?
Yes.
Is that a Sears criteria? Mm-hmm. And then I say, did you really count her respirations? Not everybody has 18 respirations. Because I was in that room and I counted myself 24. Is that important in this patient with the infection?
Yes.
Is that a Sears criteria that is telling me this infection may be entering this patient's bloodstream and this patient's immune system is responding? Yeah. So is respiration important?
Yes.
Put 18 for everybody. All right. Y'all think I don't know this. I've been around a long time. Okay, so So now, some other things are MAP. You learned what MAP means this semester, didn't you? Alright, so if a MAP is less than 70, is that one of those criteria telling you that, hey, this local infection could be creeping over to their system?
Yes.
Yes. Could they be developing sepsis? Yes. And the nurse is the one most of the time that picks up on this and tells the doctor. And because it's different at different facilities, now they are tagging the computer systems in some hospitals that if you are entering any of these, that it tags red and flows to the doctor of ting, 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 this could be SEERS, this could be sepsis. Mm-hmm. The other thing that is, so important up here, you're looking at lactic acid. Do y'all see it? There's an arrow up, and I was talking about lactic acid and venous lactic acid. You with me? What is lactic acid? Do y'all remember what it means? If someone, now it can mean many things. First, let's talk about it can mean many things. But when we're looking at sepsis, if their lactic acid level is going up, it means in this instance anaerobic metabolism. And what that means is metabolism without what?
Air.
Oxygen. Oxygen. So if that is occurring, does that mean decreased perfusion? Mm-hmm. Yes. So again, we're fixing to talk about why that is, but I want you to get that when their lactic acid level is elevating, and I gave you a for instance and told you I'm not going to test you on it, yes. But let's say their serum lactate, same thing as lactic acid. What if it is now 3? Is that elevating if I told you the high end was 2.2? Mm-hmm. And could that be a marker that now this local infection is creeping on into the blood? Mm-hmm. Okay, so do you see where your assessment is so important when you've got a patient who's infected to pick up that they could be having a systemic inflammatory response to that infection and it could be going into their bloodstream? Does that make sense? Okay, we're going to cover sepsis. I just wrote this stuff on the board to drag your hiney to it. I want you in your icky book in those areas. You with me? Okay, if I wrote it on the board, you need it. So page 765 is something called the sepsis bundle. And what bundles are is it's nationally recognized, evidence-based, best practice. Okay, if we suspect our patient has sepsis, these are the things we do. And this is how fast we do it nationwide, because this is a nationwide epidemic. It's not just at Gulfport Memorial or Singing River, it's everywhere. And this is the number one thing that patients are dying from. So what do? Well, we put forth a huge effort of education at all hospitals, and the biggest thing we want to do is prevent sepsis. So how can we prevent sepsis? Well, we teach people about infection control, washing their hands, making sure they take all their antibiotics. Y'all with me? And so prevention is the biggest thing we can do because we don't want anybody to have this happen to them. And the next thing, if we can't prevent it, then we need to recognize it quick. And then once we recognize it, we not only need to recognize it, we need to treat it quickly. And so the bundle tells you got to do these things within this time. All right? And I bet you already know the main ones that we're going to do. First thing we got to do is blood cultures, right? Culture everything. We're culturing everything we can find, especially blood. Trying to figure out what is it? What's causing it so we can effectively treat it. But we're not going to wait on the cultures. We're going to go ahead and do broad spectrum until we get the cultures back, and then we can change it. Does that make sense? Mm-hmm. Okay, and then we're going to watch their lactic acid, and because that tells us anaerobic metabolism, so it's going to tell us if the patient's getting better or worse. So we'll monitor lactic acid along the way. Does that make sense? Now, there's another marker that we do a lot, and they don't mention it much in your book, but in practice we do it a lot. And it's called procalcitonin level. And that's a marker for sepsis. That's another one. So you can just put marker for sepsis. Okay, you'll see this at clinical, I promise. And so if you have a sepsis patient on your concept map, should be lactic acid and procalcitonin. Then they're going to give an anti-infective based on those culture results. And then the other thing they do is fluid boluses because. Now, I want you to understand that sepsis is something called a distributive form of shock. And what that means is that with sepsis, remember I told you have that inflammatory response that's occurring. You're going to have massive vasodilation from the immune response, which means that person's tank, all their blood vessels are getting what? Bigger. And not only are they getting bigger, the other thing that happens is their capillaries start to leak. You get leaky capillaries. So in level 2 and in LPN school, they taught you about relative hypovolemia. That is when the fluids in the body just shift out of the vascular space. You don't see them on the floor, but they're no longer in the blood vessels. Okay, so the patient, in a sense, becomes hypotensive because do they have the volume where it's needed? No. And if you don't have the volume in your vessels, can you feed all of your major organs what they need? No. So you're going to see a lot of fluid boluses being given. And our med surge, if the fluid boluses don't bring the pressure up and start correcting all this, the patient moves to the ICU because then they're going to have to continue fluid boluses, but they're also going to have to add those really strong medications to constrict the vessels, which you can't give on a med surg floor. They're called vasopressors. And in some books, they're called cardiotonic medicines. You're given some medicines in the IV that are going to help to do what? Help constrict and perfuse. Once you constrict, you're pushing blood where? To the major organs. So you're trying to help perfusion and you're trying to save the body. Now the other thing I wanted to mention, which scares the crap out of me, I've read a lot of studies on patients who have sepsis and go into septic shock. It occurs as a process. And I'm going to show you that up here on the PowerPoint. You do not, everybody listen, you do not have to know the phases of shock. It is on the PowerPoint, and it is to make a point that this occurs in phases. And the point of it is that you'll understand better why we miss it. Okay? That makes sense? But you don't have to memorize those. And here's what scares me to death with the studies I've read. The higher the blood glucose on these patients, the higher the mortality rate. And so, we wonder why these physicians are such a pain in the butt sometimes over they're wanting glucose a certain number. Well, that's why. Is because the evidence shows that if we allow their glucose to be high, their mortality rate goes up. More likely is they're going to die. So they want, it's rated up here on the board, managed blood glucose. They want the blood glucose between 110 and 150. If it's higher than 150, especially 180, then we've got to make sure we're getting that controlled. Now, does it make sense to y'all? And I think y'all know stuff you don't know, so let me just say this. When your body is stressed, what does your liver do? It dumps what? Sugar. It dumps sugar. And so is your blood glucose going to go up in stress conditions? Yes. So again, we got to manage that because is sepsis a stress condition? Yes. Now the other thing, the worst end of this whole sepsis is your patient going into septic shock. And we can kind of know that because that venous lactic acid will go greater than 4. Okay? Which means they're having anaerobic metabolism, they're not perfusing. And if we don't turn this around, they're going to die quick. It's very hard to turn someone around who goes into septic shock. Can it be done? Yes. Probably it has a mortality rate between 50 and 80. And why do you think the nation is going to the bundle? And we're trying to do a better job, and this is why. And I'm not talking, like I told you, I'm not talking about old people. I'm talking about 30-something-year-olds dying. Now that makes me want to vomit. Okay? So another thing, the worst end also with the sepsis, septic shock, is when they go into septic shock and their system is extremely stressed, they go into something sometimes called DIC, disseminated intravascular coagulation. I'm not going to test you on DIC. DIC is a huge ICU concept. But I want you to understand what happens is from the inflammatory response, all of this clotting starts to occur. Tiny little clots in the capillary system. So in order to form tiny little clots, you're eating up all your patient's fibrin and clotting factors. So not only are all these tiny little clots in the capillaries, and the capillaries serve a lot of things. Think about your kidneys. Do you think that it could just completely cut off kidney function? Yes. So, all right, we've eat up our clotting factors. You with me? So not only are they clotting, now they're starting to bleed everywhere around all of their IVs. Any tube, they'll literally start seeping blood. That's what you see in DIC. And so the sad part is, how do we fix that? Do you anticoagulate them? Oh my God, it's a nightmare. We're giving them all kind of clotting factors back. We're trying to give all kind of blood products to stop the bleeding. But then we got the problem with clotting. So do you see how organ dysfunction happens with that? And they die. So the whole point of the phases of shock here is to show you how we can miss it so quick and how so quickly they can, once they get to septic shock, it's like this. All right, it's happening. We don't see it because they don't look like they're in shock because it's distributive. So if you're vasodilating, if something is causing vasodilation, the extremities are going to be warm. Okay? So it's not your usual shock patient that everything is what? Cold and they look bad. So distributive shock is kind of tricky. All right? So people can get septic and get really sick, and we've got to be able to pick up on the stuff early. Does that make sense? Okay. So we're going to talk about it, but I like to kind of introduce you to it, kind of like a movie trailer, and tell you what we're talking about. You see what I'm saying? And so then we will look at it together. All right, you ready to go through all this? We're going to go back through. I'm just introducing you to this. So we're going to go back through this. Okay? But we're going to take a pee break because they don't seem to be breaking like they're supposed to. Or I don't hear them. Do y'all? I don't hear them. Hold on a minute. What? You might miss something. You got a question?
I was just saying, like, you said that the capillaries are leaking, and so you have like third space filled.
Yes.
So therefore you'll see fingers swollen, like.
But it doesn't happen like that.
Okay.
And you know, I can be swollen and you not even notice. So it's not going to be like, oh my God, look at her, she's blowing up like a toad frog at first.
So it's like
It happens slowly over time.
But not severe shock that you'll see the more.
Yes.
Fingers.
Once it gets really bad is when they're gonna look like a toad frog when they're in septic shock, the DIC and all that. In the beginning, the leak is not going to be so profound, and you might even overlook it.
Or will it be hard to draw blood from them just because you're leaking?
Mm-mm. Not that much, because you're not drawing blood out of capillaries unless you're sticking a finger.
I'm just saying.
You know, you're drawing it out of a vein.
I'm not out of the vein, but I was thinking about a patient that I had that had to draw blood, and she had to get lactic acid, but
Yeah.
she put a tourniquet on, and it was hard to get blood.
And that might have been the
And her
case.
fingers were extremely swollen.
It could be, if it was bad enough at that point. I want to make sure that they understand I get your question. If I'd have known where the patient was or what was going on with them, it'd be different. But typically, they're not that swollen up until they're really bad. I mean, they're on that downslide of dying.
So that's why it's so dangerous, because you do not, there's no clinical presentation.
Right. There's a presentation, but it's subtle. It's subtle. All right, so the points from what I just said. The main points are, here's the main points. Even though this table right here, 37.4, tells you the conditions that predispose someone to sepsis, the person with the infection is the highest risk. Does that make sense? Okay, the person with an infection is the one with the highest risk. This person, or the people on this list, are predisposed for an infection in general. But the person highest at risk for sepsis is the person with a known infection. Okay? Not necessarily just the conditions that predispose the person, but with the known infection. What are some known infections?
UTI,
All right, UTI, pyelonephritis, pneumonia, cellulitis, staph infection. So you get it? So we have an infection that is escaping local area that's going into the blood, and that is called sepsis. You with me? Okay. So now, the other point that I want to make is that we now have bundles, which is evidence-based treatment, if we know someone is septic, what to do. Okay? And it tells you in what time. And this right here, to me personally, this Sears criteria that is table 37.3, and here's some of the main ones right here. Look at this, white blood cell count greater than 12,000 or less than 4,000. Why less than?
Because their body's not fighting it anymore.
cooling off.
Believe. Yes. Okay. So if you have an infection, all right, you have an infection, and your bone marrow is what makes your white cells and your red cells. Do y'all remember that? What if your body has been fighting this infection for some time, and they've already, you remember that your mature white blood cells are called segmented white blood cells. Do y'all remember that? We call them your segs, segmented white cells. They're your mature ones. They're ready for battle, okay? But your bands, B-A-N-D-S, bands, they are your immature white cells. Do y'all remember those? Well, you need to. Your bands are your little guys that are like 12. They think they some. And yeah, we could send you out to fight war, but you really ain't ready. You hear me? So what happens is, once we use up all of our mature white blood cells, once we use them all up, guess what? We got to go, well, we still got an infection. Hey, little guy, get on out there, ready or not. Get on out there and treat this infection. Come on, band, get on up. And so on the diff, and your doctor's going to ask for your white blood cell differential. He's going to be looking for that. Because in your septic patient, what happens is, you'll read something called a left shift, and the doctors will say it to you, just act big. And all that means is they have an increase in their immature or their band white blood cells and a decrease or the same in their mature. Why is their body throwing out immature white cells?
To try to fight the infection.
To try to fight the infection. So your white cells in general may go down too. All right? Plus, with older people sometimes and other disease processes, they're not able to do what?
Fight the infection.
Fight the infection. So again, that's why they give you that white cell greater than 12 or less than 4 is one of those signs that infection is entering what? The bloodstream. So do y'all kind of get it? I'm trying to explain to you what you're reading and what those criteria mean, and there's a bunch more than that. So what are some of the blood markers of sepsis? lactic
Lactic
acid,
acid
and procalcitonin. And procalcitonin is hardly in your book, but at Singing River, they use it all the time. The other thing they use procalcitonin for, and I hope this helps you, it should help you, that if you're treating a patient infection, you're treating, especially a patient with sepsis, their infection, we can draw a procalcitonin after a couple of days and see if it is what?
Getting better.
Getting better. Because if it's getting better, that level's going to come down. Make sense? All right, and that's not in your book, but you can thank me later. So that is the clinical picture. And I like to give you real life, useful information so that you can go and have a good conversation, but more so that you can understand what you're reading. How do y'all think I know what I know? It's not because someone told me in class. I promise. My instructors read the book to me. And you know how I learned what I know? I ask a bunch of questions, and I have Google, and I have, oh girl, I love looking at the newest information on stuff, because especially if my family gets it, I want to know what's the newest treatment. Does that make sense? Yeah. Y'all are just learning what you need to survive right now, so you need to really be a good nurse, look stuff up, be able to talk to people. All right, can we pee? All right, we talk.